It's really a great honor and privilege to introduce the esteemed Dr. Karen Anderson to you today. She is a psychiatrist specializing in neuropsychiatry and the director of the Huntington's Disease Care, Education and Research Center at MedStar. That's Georgetown University Hospital. Dr. Anderson sees adults, patients, and families dealing with behavioral symptoms caused by neurological conditions such as Huntington's disease, Parkinson's disease, Alzheimer's, and also brain injuries. She is an associate professor of psychiatry and neurology at Georgetown University Medical Center. Our topics today are irritability, aggression, education. Welcome, Dr. Anderson, to our Lunch with Docs HD webinar, and thank you so very much for spending this valuable time with us.
Thank you. Thank you so much for having me. I'm so pleased to be on one of your first episodes, your second episode.
We're very honored to have you.
Oh, thank you. Thank you so much for doing this educational effort. I know how important it is to get information out there to people, especially in a way they can use it and at a time when it's convenient for them. I think it's really great. And I'm going to be talking about irritability and aggression today, which are two really common symptoms that we see in HD. So for those of you family members out there and other care partners, I don't need to tell you that these are common and things that I'm asked about a lot in clinic. So this is probably one of the most common questions that families come into clinic with is, you know, what are these things? Why is my loved one acting like this? And what can I possibly do to prevent this, or at least decrease the impact on the rest of the family? So just to give you a sense so that we're all kind of on the same page with this, when I talk about irritability as a psychiatrist, I mean having trouble controlling your temper. And if you have irritability, it will usually result in some kind of a behavior, either a verbal outburst, like cussing or angry words, or even a behavioral outburst, angry behavior, thrashing around, etc. The key thing to know is that when somebody feels irritable, it's experienced by them inside. It doesn't necessarily have to be seen outside by others. So I could walk around all day feeling horribly irritable, but if I'm able to control it and really ramp down my behavior around other people, they may not know how much I'm suffering with it. The experience of being irritable is always unpleasant for the person. So if you're feeling irritable, you don't start out the day being happy that you're going around in a bad mood and looking for a fight. You really feel on edge and very unhappy, and it's a feeling that people usually want to get away from. Next. So as I mentioned, irritability is so common in Huntington's disease. Depending on how you ask the question, you know, what kind of questions you use to talk about irritable mood, 20 to over 80% of people will admit to having irritability, or their family members will report it. So a very common thing that we find in our research on irritability is that people may not realize they're irritable. So a common thing that I'll hear in clinic is everyone else has a problem. Everyone else in the family is very unreasonable. They're always on my case. They're always bugging me. And the patient themselves may not realize they're irritable. They may not realize they're the one with the problem. All they know is they're unhappy and they don't like being in that state. Next. So it can be very challenging to treat irritability. A lot of the medications that seem sort of like obvious ones to use will actually make some other things worse. So a lot of medications for irritability can make people sleepy. It might make them more likely to fall, or it might worsen memory trouble by sedating them or causing more confusion. So it's a little tricky when we start to treat irritability. We often end up using more than one medication in combination to treat irritability. This can be a good thing. It can give us more flexibility. It can give us the ability to treat things quickly and then maybe ramp them down. But it can end up being a bad thing if someone ends up on a lot of different medications and they aren't being monitored and reduced when possible. So those are some things to keep in mind. If you or a loved one is struggling with irritability, there are treatments out there, but you do need to have them monitored, and you want to make sure that they're reevaluated periodically, so that if you're on a lot of treatment, maybe in a few months you wouldn't need to be on quite so much medication. Next. This is a review of irritability treatments that we published a while back. Mark Groves is the first author, and it's available, publicly available, looking at different treatment options. And this is just to give you an idea when you ask experts, both in North America and in Europe and Australia, about how they treat irritability. These are the many medications that pop up. So it's not such a simple thing. There are a lot of treatment options that we use, going anywhere from the SSRI antidepressants, so something like Prozac or escitalopram, to antipsychotic medications, haloperidol, olanzapine, quetiapine, medications like a mood stabilizer, so valproic acid or Depakote, all the way to something like some of the older tricyclic antidepressants. So many options for treatment. Again, the trick is knowing how to use them, when to start them, and when to stop them. Next slide. So aggression is sort of irritability's even uglier cousin, right? So aggression is really when irritability starts to become more of a behavior. Next slide. So aggression is a behavior that's forceful or hostile or attacking. It can occur in retaliation. So you've asked someone to do something and they're really angry, or you've taken away something and they're very angry at you, so they strike out. Or it can be without any cause, actually. It can just come out of nowhere. And this is something that we see kind of commonly in people with Huntington's disease. It's really the intention to cause harm. So when someone acts in an aggressive manner, they are intent on harming something, either a person or an object or someone else. And it can really be verbal aggression, again, cussing and outbursts. It can be physical aggression. It can be property damage, so putting a fist through a wall. It can be harming animals, so kicking a pet. Lots of different ways that aggression is manifested in people. Next slide. One of the key factors in treating irritability and aggression is really working with families about behavioral modifications for the families and for the patients, and also teaching people to avoid triggers. So if I can identify what really upsets someone with Huntington's, what really sets them off to irritability down the path to aggression, then maybe we can learn to avoid that trigger. So the example I always have is, if somebody in your family with HD wants to control the TV remote, maybe it's better to just let them have the remote and avoid the fight, rather than fighting over whose turn it is and whether it's right or not. Certainly it's helpful to learn to walk away from conflicts. So it can be very hard if you know that you're right or you're very principled, but it's often better to walk away from the conflict and not continue to argue, because that will really escalate things. And if someone's really, really irritable and upset when they have a brain disease, it's pretty rare that you're going to convince them that they were wrong and you're right, and that you're really going to win. So it will usually just make things worse. The worst scenarios I see is when someone's really aggressive and worked up, and the patient walks away, and then the family member follows them to another room to continue the argument. That's often a recipe for really bad physical violence. And then, of course, alcohol and drugs can worsen the problem. So if somebody has a tendency to drink too much, that can really disinhibit them and cause them to act more on their irritability and become aggressive, and likewise with drugs. Next. So another part of the education that I do with patients and families is to talk about weapons in the home. So if somebody is irritable, if they have a history of aggression, definitely removing knives from the home. If someone has guns, removing guns from the home, or at least if someone likes to collect guns, separating the guns and the ammo, so that there's a little bit of time before somebody can load a gun and act on an irritable, aggressive impulse before there's a conflict. If a situation escalates, I always advise family members, leave the house. If things get really bad and you start to fear, you should, really go along with your own intuition. If you feel like a situation is becoming dangerous, you probably have very good intuition. You know your family member well. You should leave the house, and definitely take your children and any pets along, and go to a neighbor's house. And then once you're in a safe place, call 911. Let them know the situation, that it's a person with a brain disease. And of course, if there are any weapons present in the home, you really want to let the authorities know when you call. Next. So as I mentioned before, treatment of irritability and aggression, they kind of goes together. and it kind of depends on how critical the situation is. So I like to start with an antidepressant because those are really well tolerated. They don't tend to have a lot of side effects. Of course, people can be sensitive to them, but in general, people do pretty well with them. The problem with antidepressants is that they can take a little while to work. So if you have someone who's really aggressive and irritable and tearing up the house, sometimes an antidepressant just takes too long. That's when we might move into using a neuroleptic medication. So something like haloperidol or olanzapine, which can have a much faster onset of action, might have more side effects. So it might be a lot more sedating, might contribute to memory loss or confusion, but will have a faster onset of action. So maybe something we'd use temporarily. Sometimes a good middle ground is what's called a mood stabilizer. So these drugs like Depakote in particular can be very good. They do take a little bit longer to work than a neuroleptic, but they can really help to ramp down the irritability faster and usually are a bit stronger than the effect from the antidepressant. And then the last category of medicines I want to mention, benzodiazepines. These can be a good option. However, some people get disinhibited by benzodiazepines. So for some people, having a benzodiazepine like lorazepam or clonazepam, so an Ativan, for example, actually feels like having a few drinks and they get disinhibited and they might get more aggressive. So that's just something to know that for some people it's a great option. It helps them to calm down very quickly. Not a great long-term solution because of the potential for abuse, but short-term they might be helpful. But if your loved one is put on benzodiazepines and you find that they actually get more aggressive, it may be that they're just getting disinhibited from them. So now that I've told you about the current treatments that we have available for irritability and aggression, let me talk for a second about a study that we have going on. So this is through the NeuroNext network. This is a network that NIH has set up to do clinical trials in neurological disease, and it's the NN105 STARE study. So this is the first study we've ever had for treatment of irritability and aggression in Huntington's disease, the first well-controlled study, placebo-controlled with a large population of patients. And this is studying a compound called a vasopressin antagonist. Next. Next slide. So this question of vasopressin, so you're saying right now, I haven't heard about vasopressin in Huntington's. I didn't know it was affected. What is it? Well, vasopressin is actually something that we all have in our bodies. It's associated with elevated aggression when they've done studies in numerous species, in fact, including humans. So the vasopressin 1A receptor is distributed in parts of the brain called the limbic system. And that's part of the brain that really regulates emotion and contributes to our reaction when we become irritable and aggressive. Next slide. So the question, is vasopressin affected in HD? How come I haven't heard about it before? We actually don't know. We think the vasopressin system may be just fine in HD, which is actually good news because that means that our drug can go in and act on it and help to ramp down irritability and aggression. And really, disease-modifying treatments that slow down the progression of HD are still many years away. We're hopeful about all the studies that are going on, but if we had a symptomatic treatment available now that could provide relief from irritability and aggression, it would be great. Next slide. So this just again shows you a little bit about the involvement in the brain of the vasopressin system, in the limbic system, and again, that the receptor that we're targeting is expressed in the brain. Next slide. So the important thing to know is that the NN105 study is actually enrolling people now at multiple sites in the US. These are the two websites you can go to find out if there's a site near you. And there is money available for travel to participate in the study. You should know that it is placebo-controlled. So if you go into the study, you do have a chance of being put on a sugar pill. But it is a great study to look at irritability in HD and to see if this particular compound may be helpful for patients and families that are suffering from irritability and aggression in Huntington's disease. I think that's it with my slides.
I have a question regarding the vasopressin. Have they clinical trialed this compound in other conditions?
They have. Yeah, so they have looked at it in other brain disorders, and they have some promising preliminary data, but it's not approved for use in any other condition yet. So, you know, Huntington's could be the first.
Okay. Just for you. Uh, Sarah did it, she said. Okay, have they looked at cognitive behavioral therapy for HD? That's the question that I got.
Yeah, you know, that's a great question. So cognitive behavioral therapy, for those of you that aren't familiar with this, is the type of therapy where you are identifying negative thoughts. You identify them, you might write them down and do homework with them that would involve teaching yourself to identify the thought and then really test it through reality and then counter it. So a negative thought might be something like, I have Huntington's and I'm going to die in a year and I can't do anything at all. So you write that thought down and then you might counteract it with, well, I have Huntington's, but I likely have many more years left and I likely have many things I can do. In fact, these are the things that I did yesterday that I enjoyed. So yes, there are things that I can't do anymore, but these are the things that I can still do that I really enjoy doing. And these are the things I want to be able to enjoy. And then setting goals for doing positive things. I don't know of any studies that have been published in cognitive behavioral therapy in HD. I think it's a wonderful intervention, especially early on. It doesn't involve medication. Cognitive behavioral therapy is typically a really short course of treatment, so it's a few weeks of therapy. It's not months and months of therapy. And I like the fact that it's, again, you know, sort of focused on catching negative things and negative thoughts and then turning them around and figuring out a positive way to act on them. But I don't know of any studies that have been published on cognitive behavioral therapy for HD specifically.
Very good. I was kind of interested to find out, with your numbers of years of experience working with Huntington's disease and the behavioral and, you know, irritability, aggression, is that something that kind of pops up first as far as manifesting symptoms, or?
You know, it's really interesting because I found that in some cases when you talk with family members, they'll report symptoms going back many years. They'll say even before the onset of movement symptoms, someone really had a lot of irritability. They were always, you know, sort of, you walked on eggshells around them. They were somebody who was likely to fly off the handle. Not always the case, but many times you will find that some of these symptoms come up quite early. In fact, they're often things that lead to job loss. You know, if you're irritable, you're not necessarily the person everyone wants to have at the next desk over in an office. So these are symptoms that are seen really throughout the span of the disease. Sometimes they seem to kind of go away in the later stages. So sometimes people who are quite irritable when they first develop symptoms and in the middle part of the disease will really become much less irritable, probably as they get more apathetic. So as they have less motivation to act on things, they might seem to be less irritable. In other cases, of course, people become irritable late in the disease for the first time. So they're interesting symptoms because they seem to appear at different stages in the disease in different people. And again, not everyone has them, although a pretty high percent of patients do really have them.
What are some tools for care partners?
If you are a care partner and you have the time to go to a support group or to individual therapy, I think it's really helpful to be able to step out of the environment and talk to someone else about it. I realize that's a tall order for a lot of people to find the time to do that. You know, and I'm hoping that some of the virtual support groups and some of the you know, other tools that are being provided now, where you don't have to leave your home, where you can actually do this from your home, will be helpful, particularly some of the things that HDSA has available for people now, so that they can really access counseling services. I think that's one of the most helpful things. If you're not able to do that, I think having somebody outside your immediate family that you can talk with is really helpful. You know, because it's one thing for me to say in the office, oh, you know, just walk away from it, it's not a big deal. But obviously when someone is in your face and yelling, and you've had no sleep, and you know, the next day is going to hold more of the same, I think it's always hard to just be calm and walk away and go to the next room. It can be really hard to remember that. Things to think about, and they may seem obvious, but they can be hard, you know, when you're taking care of someone, to remember is people with HD sometimes don't have great awareness that they've become thirsty or hungry, or even that they need to use the toilet. So if someone is irritable, sometimes it's great to just kind of step back and think to yourself, oh, have they actually had a lot of water today? You know, it's very hot out right now. Have they really had a chance to hydrate? Could it be that they're hungry? You know, if I offer them a cookie and distract them, will that actually, you know, fix this for a minute? Or conversely, you know, am I giving them caffeinated drinks all day and have I gotten them revved up on caffeine? You know, if somebody has trouble communicating, if they really have a lot of difficulty talking, you know, are they sitting near the air conditioner and so there's air blowing on them all day and they're cold, but they can't tell you that and it's making them irritable. So some of the simpler environmental things can actually make quite a bit of difference too. But it can kind of, it can be hard to recognize them sometimes. It can be hard to think about them when you're living in it all day in your own home.
That's a really good point, because sometimes they're just not verbal. And you have to kind of be a detective in some ways to try to find out what it is that is the root cause of the aggression. We know that it happens easily in HD, but what are the contributing factors, and how can you maybe anticipate some of those factors and try to make things a little bit more comfortable, so to speak?
Absolutely. I mean, I think, you know, when I go out to long-term care facilities, I talk about this a lot where, you know, someone might get constipated. So a lot of these medicines that we use to treat irritability, like haloperidol, olanzapine in particular, the benzodiazepines, they can make people really constipated. And if you're not vigilant, if you're not aware that, gosh, it's been a couple days since they had a bowel movement, you know, maybe they're constipated, but they're not telling you and they can't tell you. Or maybe they have a urinary tract infection because they sit a lot, it's difficult for them to get to the toilet, and they're really uncomfortable, but they can't tell you that they have horrible burning or horrible pain. So those are the kind of things that, again, you know, as you said, you sort of have to be a detective and you have to think a little bit about, you know, what is it here that's not so great? Another common one is patients who become agitated in long-term care around change of shift. Well, everyone's running around, people are not paying attention to them. Maybe they're hungry, but they don't get their snack on time because everyone's, you know, finishing up their paperwork and going home for the day. So is there any way to fix that? Is there any way to make sure someone spends a little time with them right before change of shift or gets them a snack right before change of shift? That's hard. You know, people have their own priorities. The people who work there want to get home too. But some of these smaller behavioral changes can go a long way to keep someone from needing a lot of medication, which is always our goal. The other thing I would add is, as I said with my slides, you know, people use a lot of different medications to treat irritability and aggression. It's really important that you periodically step back and take a look at this and say, you know, 6 months ago, he needed to be on 10 milligrams of haloperidol because he was throwing dishes and, you know, it was horrible. But maybe now we could go down to 5. Maybe now we could stop the haloperidol and just have a dose of an antidepressant to control some of the symptoms. So, you know, really reevaluating how much medication someone needs to be on so they don't end up on large doses of medication for a very long time.
Over sedating is not necessarily a good thing, right?
Absolutely not. No, that's never our goal. There may be some very short periods of time where someone needs to be a little sedated because they've gotten so out of control. But long-term, that is never the goal.
And I think that's a problem in the care facilities, isn't it?
It's a problem everywhere because, you know, even at home, you know, if a family has gone through a terrible period where someone literally puts their fist through the wall and throws the toaster and the rest of it, everyone's really scared to reduce medication. And, you know, it makes sense. You don't want to go back to that if you've lived through a terrible period where the kids are afraid to be in the same room with their parent. But on the other hand, you know, you don't want to keep someone sedated for a long time either. So it really is a balance, and it really is, you know, removing things very slowly, not making big drastic changes that are going to set everyone back.
First of all, I want to thank you so much for all of this. I want to apologize because for some reason I don't have your picture up. Your video seems to have stopped working. So I apologize, everyone, for that. And there was another question. Let me see. Do we know what % of individuals experience aggression?
Yeah,
Anything?
aggression, again, it's probably about 50% of individuals. And this is counting a wide range of behaviors as aggression. So aggression can be verbal aggression, yelling, shouting. It can be physical, as in I shake my fist at you in a threatening way, or it can really escalate to, throwing things or even hitting other people or hitting pets, for example. So, it can be quite a range of behavior that we count as aggression.
Right. Let's see. Okay, so I was still trying to get your video to work, but it's not working. Okay. I'm so sorry. At least we have the verbal recording and, oh, I know. Vasopressin. Did we talk about that one being used for other conditions, and what other conditions were they using it for?
We did. So it's been studied in other brain disorders, yeah. But as I said, it has not been approved for anything yet, this particular compound. So, HD could be the first disease for which it's approved.
Do we know the outcome of those studies?
No, we don't have definite outcomes yet, no.
Okay. All righty. Karen, again, I just want to tell you thank you so much for spending this time with us. It's such a pleasure and an honor to have you with us. So,
thank you. I'm so happy to be a part of your program, and good luck on your future shows. I'm sure they'll be great.
Thank you, and hopefully we'll have video. So without further ado, thank you all for joining us, and we'll be posting this on YouTube, and we'll be sending it out through Facebook and Twitter and Tumblr and all the good stuff that's out there. And please let us know. Give us some feedback, if you will. You can find us on our websites at hdscn.org and pmdalliance.org. So thank you all for joining us. Have a great week. Talk to you soon.